Good afternoon, everyone. Now it's time for general hepatology session. We have three speakers in this session, and at the end of the session, we will have case-based discussions.
Hello, everybody. I'm extremely privileged to chair this session today together with my co-chair, Professor Fatih Beşişik. In the past few years, TASL and ASLD build up fruitful relationships. Connect meetings that we are enjoying one of them today are one of the most important outputs of this cooperation. In this session of the meeting, we will be discussing various issues within the framework of general hepatology. At the beginning, three distinguished speakers will make their presentations. Dr. Aparna Goyal will present immune-mediated liver disease, including immune checkpoint inhibitors toxicity. Then Dr. Elliot Taper will talk about long-term complications of liver transplantation. And then Dr. Elizabeth Varna will present a debrief of important studies related to general hepatology from the ASLD 2021 meeting. Then we will continue with case presentations. Now I would like to invite our first speaker, Dr. Aparna Goyal. Microphone is yours, Dr. Goyal.
Good afternoon, everyone. I'd like to thank the course organizers for inviting me to provide updates from the liver meeting on immune-mediated liver disease. My name is Aparna Goyal, and I'm an assistant professor at Stanford University. We'll begin with a review of primary biliary cholangitis. As you know, PBC is a chronic progressive autoimmune cholestatic liver disease that's characterized by impaired bile flow, portal inflammation, and destruction of the small intrahepatic bile ducts. It affects nearly 1 in 1,000 women over the age of 50, so approximately 130,000 women in the US. It's characterized primarily by fatigue, pruritus, and jaundice. Alkaline phosphatase and bilirubin are important prognostic risk factors for PBC, and these are clinical surrogates for slowing PBC progression. This is demonstrated by the survival curve differences noted here in PBC patients with abnormal and normal bilirubin levels stratified by their alkaline phosphatase levels, with alkaline phosphatase levels less than 1.67 times upper limit of normal, providing a more favorable prognosis. The graph on the right indicates survival differences in those with abnormal bilirubin. In the red, those with the bilirubin between 0.6 times upper limit of normal and 1 times upper limit of normal. In green, in those with a bilirubin of less than 0.6 times upper limit of normal in blue. Current treatment options for PBC highlight unmet needs. So first-line treatment option includes ursodeoxycholic acid or UDCA, but approximately 40% of patients are inadequate responders with persistent elevation in alkaline phosphatase after 1 year of therapy, and 5% are intolerant to therapy. Add-on therapy includes obeticholic acid or monotherapy if patients are intolerant to UDCA, but approximately 50% of patients are inadequate responders to obeticholic acid, and pruritus can worsen or develop with this therapy. And lastly, liver transplantation is reserved for those with end-stage liver disease. So we'll review the study presented by Marilyn Mayo on behalf of Synovate Therapeutics on the long-term safety and efficacy of seladelpar in patients with PBC, the 2-year results from a long-term study. So seladelpar is a PPAR delta agonist in development for liver disease. It induces activation or repression of multiple different genes that result in favorable properties, including a reduction in bile acids, in anti-inflammatory, anti-fibrotic activity, and an increase in lipid metabolism. These are the results of the long-term extension from the phase 2 dose-ranging study of seladelpar. So patients with an inadequate response or intolerance to UDCA were enrolled if they met study criteria. 102 patients completed 1 year, and 53 patients included 2 years of the study before the study was terminated by the sponsor. The primary endpoint was % change in alkaline phosphatase from baseline. And as you can see here, the mean alkaline phosphatase drop was 42% at 1 year and 50% at 2 years. The alkaline phosphatase continued to decline during the second year of treatment. This is the % change value, and this is the absolute value of the alkaline phosphatase during therapy. The composite endpoint, which was an alkaline phosphatase less than 1.67 times upper limit of normal, greater than 50% decrease in alkaline phosphatase, and a total bilirubin less than upper limit of normal was achieved in 64% of patients at 1 year of treatment and 79% of patients in those completing 2 years of treatment. Alkaline phosphatase normalization was achieved by 24% at 1 year and 42% in those completing 2 years of treatment. And in those that had a total bilirubin that was greater than 0.6 times upper limit of normal on steady entry, 34% had an improvement in bilirubin to less than 0.6 times upper limit of normal at 1 year and 37% at 2 years. Adverse events leading to discontinuation of seladelpar were rare, and treatment-related adverse events included nausea, pruritus, and diarrhea. And with these promising results, there's a 52-week phase 3 study that is currently enrolling globally. Dr. Cynthia Levy from the University of Miami presented additional findings of seladelpar in PBC patients with compensated cirrhosis and portal hypertension. This was pooled analysis of patients that were enrolled in the open label phase 2 and the placebo-controlled phase 3 studies, and included a total of 22 patients. And as you can see here, there was significant reductions in the alkaline phosphatase in those with compensated cirrhosis with and without portal hypertension in both the 5 milligram and the 10 milligram doses of seladelpar. The composite endpoint was achieved in approximately 60% of those that had compensated cirrhosis with portal hypertension at the 10 milligram dose as well. We'll change gears now and talk about primary sclerosing cholangitis. So primary sclerosing cholangitis is a highly variable process. It is a chronic, slowly progressive cholestatic liver disease with many clinical subtypes. The clinical subtypes include large and small duct PSC, that's the PSC that's associated or not with IBD, overlap with autoimmune hepatitis, and IgG4 cholangiopathy. Current therapies for PSC remain absent. Ursodeoxycholic acid is commonly used at a dose of 17 to 23 milligrams per kilogram per day, and it may improve liver biochemistries, but does not result in changes to transplantation rates or survival benefit. Higher doses have resulted in higher mortalities. ERCP is used for biliary strictures, and really the only proven therapy is liver transplantation in those that progress to more advanced disease. But fortunately, this is an exciting time for PSC. There's currently many drugs in the pipeline, and as more clinical trials are pursued, our understanding of the disease also improves. There are many mechanisms for disease modulation that are shown up here, and we won't have time to review all of these medications, but I'll focus on 2 drugs that were presented at the recent liver meeting. Remember, it is still unclear which clinical endpoints are meaningful for PSC in terms of disease progression and, or improvement of disease. So this is a proof of concept study of HTD-1801, berberine ursodeoxycholate in patients with primary sclerosing cholangitis that were not previously exposed to UDCA. This was presented by Dr. Gideon Hirschfeld. So HTD-1801 is an equimolar ionic salt of berberine and ursodeoxycholic acid. Berberine is a molecule that has been used for some time for the treatment of diabetes and is under investigation for the treatment of non-alcoholic fatty liver disease as well. It has several favorable properties, including anti-inflammatory, anti-cholestatic, anti-fibrotic, and antimicrobial effects. And as you know, UDCA is a choleretic and an anti-inflammatory. So the combination of these two, which is modifies the physiochemical properties, and it improves the bioavailability of berberine. And preliminary results of HTD-1801 show significant reductions in alkaline phosphatase with just 2 doses of the drug. However, these changes in cholestasis were more modest in those that were previously treated or had previously received UDCA. So patients, the aim of the study was to assess changes in alkaline phosphatase and other biomarkers of PSC. With HTD-1801 in subjects who had not previously received UDCA. Patients that were included had a confirmed diagnosis of PSC by MRCP or ERCP with alkaline phosphatase values greater than 1.5 times upper limit of normal, and patients that had overlap or small duct PSC were excluded. So this is the original study design of the phase 2 double-blind placebo-controlled study. 55 patients were initially randomized and treated, and of those, 33 had no prior UDCA exposure. The effects were observed during period 1 of the study between day 0 and week 6 in those that were not previously treated with UDCA, and these patients were included in the analysis. A total of 32 patients ended up being included in the analysis. So as you can see here, HTD 1801 results in rapid reduction in the alkaline phosphatase within a short period of time. On the left, you can see the decline in alkaline phosphatase from approximately 400, ending at 200 after just 6 weeks of therapy. And this is quite distinct from the placebo group. And then when evaluating specific alkaline phosphatase thresholds, you can see that 71% of subjects who received the higher dose of HTD at 1,000 milligrams twice a day had a 25% reduction in alkaline phosphatase, and nearly 1/3 had a 50% reduction in the higher dose group as well. 43% of subjects achieved an alkaline phosphatase less than 1.5 times the upper limit of normal, and then 14% of patients were able to achieve alkaline phosphatase normalization with a higher dose. There was also improvements noted in AST, ALT, and GGT, and bilirubin stayed stable throughout the study period. The expected side effects included diarrhea, nausea, and vomiting, and there was no treatment-related study discontinuations during the 6-week period. We'll review the next study for primary sclerosing cholangitis with cilofexor. And the aim of this study was to review the safety and preliminary efficacy of the farcinoid X receptor agonist cilofexor in a 96-week open label extension of the phase 2 study of PSC. This was presented by Michael Troner at the Medical University of Vienna. So cilofexor is a selective non-steroidal small molecule FXR agonist. And as you know, FXR is a key regulator of bile acid homeostasis that results in reduced inflammation, fibrosis, and increased bile acid export along with decreased bile acid synthesis. These results here are actually results from the 12-week phase 2 study that showed a dose-dependent reduction in markers of cholestasis and alkaline phosphatase, with a mean reduction of approximately 21% in the cilofexor 100 milligram group after 12 weeks of therapy. And cilofexor is currently being evaluated in a phase 3 study called PRIMIS, which has actually completed enrollment, and we await the results of this study. So this is the study design. After patients completed a 12-week phase 2 study, they were offered to enroll in the open label extension. There was a 4-week washout period before the 96-week open label study. The key inclusion criteria included patients that did not have cirrhosis and had large duct PSC with an alkaline phosphatase greater than 1.67 times upper limit of normal and a total bilirubin that was less than 2, and patients had to have stable IBD. So in the 47 patients that enrolled in the open label extension, 45% were on UDCA. Median alkaline phosphatase value was 368, bilirubin value was 0.8, and the ELF score was 9.5. These are the results of the 96-week open label extension. So there was an 8% reduction in the alkaline phosphatase after 96 weeks. There was approximately a 30% reduction, which was clinically significant in GGT and ALT, and there was a 17% reduction in AST from the baseline. The alkaline phosphatase reductions in response was similar in those receiving UDCA and those that were not. The alkaline phosphatase trend during the study period is shown in this graph over here to the right. So you can see that there was a significant early decrease in alkaline phosphatase that was sustained until the last 2 study points, and then there was a rebound in the alkaline phosphatase after discontinuation of the study drug. There was a statistically significant increase in ELF score by 1.7% at the end of the study period. And in terms of safety, there was no treatment-related serious adverse events, and treatment was discontinued in 10 patients, 5 due to pruritus, and pruritus was the most common treatment-emergent adverse event. The last study we'll review is on immune checkpoint blockade hepatitis. Unfortunately, there was not too much at AASLD on immune checkpoint inhibitor hepatitis, but we'll conclude with an interesting spatial study here. So this was a presentation by an MD candidate in Germany, whose name is Lawrence Krimmel, entitled High Dimensional Analysis of the Hepatic Immune Infiltrate Identifies Differences Between Autoimmune and Checkpoint Therapy Associated Hepatitis. So immune checkpoint therapies targeting PD-1 and PD-L1 and CTLA-4 have dramatically improved outcomes in clinical oncology, but frequently cause immune-related adverse events, and such as hepatitis. And while most cases of immune-related adverse events are mild, approximately 20% of those receiving combination therapy with anti-CTLA-4, anti-PD-1 may experience grade 3 to 4 toxicity. And in particular, the onset of hepatitis typically occurs 7 weeks after beginning therapy. So there's the goal of this study was to provide a detailed analysis of the immune infiltrate and the spatial composition of immune checkpoint blockade hepatitis in comparison to autoimmune hepatitis using imaging mass cytometry. We know that the classic histopathologic features of autoimmune hepatitis include interface hepatitis, lymphoplasmacytic infiltrate, and rosette formation. The histopathologic features of ICB hepatitis have not been well classified yet, and there are several patterns that have been reported, including a granulomatous hepatitis, central vein endotheliitis, and elevated CD8 to CD4 ratios, but there's significant heterogeneity in what has been reported. So IMC, or imaging mass cytometry, is a rather complicated process that involves labeling of tissue with metal antibodies followed by time of flight mass cytometry, laser ablation, and machine learning to ultimately obtain a very beautiful picture like the one that's shown up here. So this is an example of a patient that has autoimmune hepatitis with both the H&E and the IMC stains up here. And as you can see in the IMC stains, that there's a significant expansion of the CD20 cells, which are indicated in the teal blue up here, and CD4 cells in the red, in this sort of follicular-like infiltrate. So in this study, histopathology from 3 different groups of patients were compared, including patients with type 1 autoimmune hepatitis, immune checkpoint blockade hepatitis on both combination therapy and monotherapy, and a control group. The median ALT level was higher in those with combination therapy, immune checkpoint blockade hepatitis, but this was not statistically significant, and the grade of hepatitis was similar between all 3 groups. I think this visual beautifully illustrates the difference and the main take-home message of this study between ICB hepatitis and autoimmune hepatitis. So on the left, you see ICB hepatitis, where there is CD8 T cell rich infiltrate around the central vein. The central vein is highlighted in the white up here, and the CD8 cells are highlighted in the green up here. And this is a characteristic CD8 positive infiltrate. On the right, in autoimmune hepatitis example, you see the strong follicular structure with the high density of CD20 positive B cells and the CD4 positive T cells. And the central vein, again highlighted in white, looks relatively bland and spared with relatively few T cells. And this really demonstrates the differences in cellular infiltration and the spatial involvement of these 2 diseases. It's apparent that there's a greater number of CD4 positive T cells and B cells in autoimmune hepatitis compared to ICB hepatitis. The results also demonstrate that the immune infiltrate in ICB hepatitis is mainly dominated by CD8 positive T cells. There was a correlation that they demonstrated with clusters of Ki67 positive and granzyme B, which correlated with the ALT levels and the grade of hepatitis. The zonation mapping revealed immune clusters primarily around central vein in those that had ICB hepatitis. And in conclusion, this study hopefully highlights potential targets for future therapy of ICB hepatitis, which we all know remain lacking. So thank you for your attention, and I look forward to any questions during the panel discussion.
Hello, it's my privilege to be with you today to discuss long-term complications of liver transplantation. I'm Elliot Tapper, an associate professor at the University of Michigan, where I am a transplant hepatologist. I have some disclosures, but they are not pertinent to this topic or at this time. So I wanted to start out by sharing with you the last truly multidisciplinary guidance document that's been provided for this space, published in Liver Transplantation nearly 9 years ago. The long-term management of the successful adult liver transplant has practice guidelines. and it's great as a touchstone for conversation. But I think we have to admit that we've learned a lot about the complications after liver transplantation that are not contained in this guidance document. And so it is at best a starting point. If one looks at published series of patients who've lived a long time after transplant, as in this case from the United Kingdom, where a single center followed patients for up to 30 years. They counted the number of people who had complications, and we learned that the common ones were things like biliary anastomotic strictures, metabolic complications, and malignancy. And I think what this gives us, albeit with old data, is a sense of what our priorities are for the next few minutes that we have together. I wanted to start with biliary strictures, the Achilles heel of liver transplantation. Always heartbreaking when this results in long-term graft morbidity and loss. Our standard approach to treating these strictures at the anastomosis has been ERCP with plastic stents, but this requires frequent stent exchanges, several ERCPs, exposing patients to potential risks and the healthcare system to multiple costs. The most recent randomized trial in this field came from a single center in Brazil, where effectively 30 patients were randomized to receive self-expanding metal stents or multiple plastic stents. And what they find is that failure rates were comparable, albeit a little bit higher in the metal stent arm, largely due to migration. But the metal stent arm resulted in markedly fewer ERCPs required to fully treat the stricture. The trade-off here was a shockingly high rate of pancreatitis, which the authors attribute to not having done sphincterotomies prior to the metal stent placement. So although this is the most recent data, it is single center, and it may not generalize to your practice where there may or may not be more experience with this condition and this approach. So for that reason, I would draw your attention to the multi-center study from the United States led by Greg Cote, where 70 patients were randomized in each arm to receive plastic stents or a single self-expanding metal stent. These were benign biliary strictures, and the majority of the patients in each arm who were included in this analysis had anastomotic strictures after liver transplantation. And here the pancreatitis rate is not very high. In fact, there's no difference between the two. But what you see is that the time to resolution of the stricture is much faster in the metal stent arm, and it requires far fewer ERCPs. And so in general, when one is dealing with anastomotic strictures, this, I think, has been one of the major changes in approaches since that guidance document was published. So now we're going to focus on extrahepatic complications, and the table of percentages beyond that which was provided by that single center from the United Kingdom tells us roughly that more than half of our patients are going to develop metabolic syndrome, particularly hypertension and diabetes. Many will develop chronic kidney disease, and some will sadly require dialysis after liver transplantation. And so as we start to think about our approaches to this, clearly the major offender here is the calcineurin inhibitor. And so it is very important to try to get patients down to the lowest effective dose. And sometimes if that would require the use of second agents like mycophenolate mofetil to allow for the lowest possible dose of tacrolimus or cyclosporin, our patients will be benefited in the long run. Because after they survive that first year, and we're no longer worried about plumbing issues like strictures, we have to keep in mind the cardiovascular health of our patients. Now, another thing that befalls patients who both have a history of things like alcohol use, smoking, viral hepatitis, and are now placed on immunosuppression is that there is an increased risk in skin cancer. An increased risk in other forms of malignancy, such as lymphoma, oropharyngeal cancer, esophageal cancer, and lung cancer, and particularly as it varies based on etiology for liver transplantation, particularly for those with primary sclerosing cholangitis, colorectal cancer. And knowing this epidemiology, one can begin to apply to our patients a table of screening that will help prevent the progression of these conditions. So for example, for skin cancer, it should be standard that we are teaching our patients to wear sunblock, to wear long sleeves in the sun, to wear hats on their head, and to see dermatologists on an annual basis. For lymphoma, the best strategy that we really have is to try to limit immunosuppression as best we can and as quickly as we can. For head and neck cancer, particularly for patients who had a history of alcohol use disorder and smoking, one should consider screening with regular dental visits. And since the publication of this table, we now have large multi-center studies that suggest that screening for lung cancer in high-risk people using things like high-resolution but low-dose radiation cross-sectional imaging is helpful to identify lung cancer at a time when it can be cured. Now, when managing the metabolic complications of liver transplantation and focusing on lipids, one tends to see somewhat complicated tables regarding risk stratification. And while the tables that were published in the prior guidance and subsequently in highly cited review articles, such as this very nice review article from Dr. Kim Watt at the Mayo Clinic, since these have been published, there are now new risk calculators such as the ASCVD, and the thresholds for treating people with statins are found on those publicly available calculators. But essentially what's driving these is whether or not people are high risk, if they have known atherosclerotic disease. If you see on a CAT scan that someone has lots of atherosclerosis in their heart or their abdominal aorta, if they've had a heart attack or if they have symptomatic peripheral artery disease, there's no real question here. This person needs to be on a high intensity statin. If the patient has risk factors like a family history, or they have they're smoking or have high blood pressure, these are patients where you would want to initiate therapy at a slightly higher threshold of low density lipoprotein. And what therapies are we going to use? And depending on the review articles that you read, you'll hear about specific statins that are recommended. But I'm not sure how well that squares with the data. So for example, if we went exclusively on the basis of drug information, there are no real interactions between tacrolimus and the commercially available statins. But if you don't believe that data and you want to rely on guidance documents, which come and go, I have for you here a table with the suggested dosing for a variety of different statins, depending on which guidance document that you're interested in looking at. The key thing to remember here is that tacrolimus does not interact with cytochrome P450, whereas cyclosporin does. So if your patient is on cyclosporin, I think it behooves you to be a little more careful and to choose your statins more wisely. But if your patient is on tacrolimus, the goal here is really to choose a statin that's going to help you hit those targets when it comes to lipid lowering. Now, many of our patients will develop diabetes or have pre-existing diabetes. And again, if one looks at guidance documents, such as this one published in Transplantation in 2017, you can see that very quickly our field is out of date. So, for example, the threshold by which a nephrologist begins to hold metformin is at a much lower GFR than the one recommended here, a GFR of 60, because the risk of lactic acidosis has been largely overblown. You also do not see and hear any mention of the GLP-1 antagonists, such as semaglutide or liraglutide, both of which are associated with weight loss in addition to A1C control. And you don't see any mention here of SGLT2 inhibitors, which are both associated with improvement in A1C, weight loss, and have long-term data showing overall survival benefits for people with and without severe chronic kidney disease. And so when your patient has diabetes, particularly if your patient has renal insufficiency, considering drugs like SGLT2 inhibitors are going to be crucial to stemming the tide of those extrahepatic comorbidities that we know are increasingly common for our patients. Our goal is to keep our patients off of dialysis. And if we want to do so, we're going to need to stretch our comfort level beyond the kinds of medications that are cited in the tables of guidance documents. Now, it is a joyous occasion when a patient gets pregnant after liver transplantation. It makes you feel as if the promise of liver transplantation has been fulfilled, as this person is now returning to life. Now, obviously, when someone is pregnant, they cannot be on medications which are directly toxic to fetal growth. And in this sense, there must be counseling around the use of mycophenolate mofetil. But even if you are doing that already, what can you tell your patient who is planning to get pregnant about the potential risks to them? Well, the rate of miscarriages in this population is probably no different than the general population. But what is different is the rate of preterm birth, which is 32%, preeclampsia, which is 12%, both of which are threefold higher than the general population. And cesarean delivery is at 42%. So understanding these things is crucial to counseling, so patients know about the potential risks, and that they are aligned with high-risk obstetric care at an early stage. Now, as we start to extend our gaze beyond the kinds of things that were mentioned in those guidelines, I want to bring up the role of quality of life and functioning. Because it turns out that if you look at old studies, you hear that quality of life after liver transplantation is the same as the general population, with the exception being physical activity and restrictions from things like work. But I think the problem here is reporter bias. And it's that we're really only asking the people who are alive and well enough to do these kinds of surveys. And it doesn't square well with my own personal experience. And so when one starts to look at the most well-done studies, you can start to see some important disparities in personal growth. So this is a paper now 1 to 2 years old, and it comes from the SPLIT consortium. So this is the national group in the United States that looks at outcomes for pediatric liver transplant. It doesn't obviously generalize perfectly to adults, but this is some of the best data that we have. And what it shows you is that if you look at liver transplant recipients at year 3, their quality of life, both as they report and as their parents report, is substantially lower, particularly for psychosocial functioning and cognitive functioning and school function, compared to the age and sex matched healthy sample. And sadly, you don't see any improvement, or for that matter, worsening over time. So as soon as they survive that transplant, by year 1, their quality of life appears to be relatively fixed. And I wonder what's really driving this. We have some emerging evidence from the same split consortium that patients who are able to come off of calcineurin inhibitors begin to have improvements in their cognitive and social functioning. And so if our interest is in improving quality of life, it's really to try to minimize the dose of calcineurin inhibitors or to develop strategies to avoid them altogether. And if you look at this performance in dichotomized black and white fashions, you can see that people who've had a liver transplant report severe, important, clinically meaningful cognitive dysfunction, school dysfunction, and poor quality of life. And this is an important unmet need, both for pediatric transplant, and I would wager that this is what I see in my adult population. Now, obviously, the sources of health-related quality of life are quite broad, and here's a conceptual model published last year, which gets at not only the things that we feel like we can control surgically and medically management, but also the various other factors that play into the social and physical contributions to health-related quality of life. And the point of this busy figure is not to throw up your hands and say, well, it's complicated, we can't do anything about it, but rather to say that if you see your patients struggling, to try to sort out, either with their primary care doctors or a psychologist, what the unique sources of their health-related quality of life deficits might be. There are people who are interested in this, like my colleague, Dr. Marina Serper, who's particularly interested in trying to redefine success after liver transplantation, focusing not only on survival, but how much people can thrive. And here, it's obvious that we can do some things. We can simplify medication regimens. We can limit calcineurin inhibitors. We can do remote monitoring. We do home-based diet and exercise programs to get people moving. We arrange the appropriate support for mental health and substance use needs. And we do it early. Our responsibility to our transplant recipients does not end at 1 year survival, but looks like this: arranging for them the holistic supports that are needed to thrive after liver transplantation. So I think the keys to optimizing outcomes and preventing severe complications after transplantation are at a minimum, cancer screening, improving metabolic health through a combination of lifestyle interventions and intensified management of dyslipidemia and diabetes, and to broaden our scope to think more about the health of our patients, not only in terms of things that we can measure on blood tests like the A1C, but also quality of life, and doing the work of trying to sort out where those deficits are coming from. And so the opportunities here are to adopt and expand ways to reduce tacrolimus, to reduce costs. It could be as simple as adopting covered metal stents, and to not accept the old data, to update our review articles to focus on the standard of care that one would receive if they had diabetes without a liver transplant. And with that, I'll conclude. Thank you for your attention.
Hello, and thank you for this opportunity to provide for you today a debrief of the new clinical hepatology data that was presented at the 2021 AASLD liver meeting. My name is Elizabeth Verna, and I'm from Columbia University in New York. Here's my disclosure, but more importantly, I want to stress that it really was not possible to capture all of the great work that was presented at the liver meeting this year. And in particular, I've excluded all work that was related to fatty liver disease, viral hepatitis, and HCC, as these topics are being covered elsewhere in this meeting. And I'll start by highlighting some of the new work presented in chronic liver diseases in particular. I will start with recent advances in our understanding of alcohol-related liver diseases, including this important study from the Framingham Heart Study, evaluating the association between alcohol use patterns and liver fibrosis based on VCTE. In this cohort, although the proportion of heavy alcohol use was small, a multivariate analysis, drinks per week, frequency of drinking, and risky weekly drinking were all significantly associated with fibrosis, even after accounting for sociodemographic factors and metabolic syndrome components, and that perhaps modest alcohol use below the current level recommended by our guidelines may also contribute to hepatic fibrosis. So what about alcohol use among those who already have established liver disease? In this multicenter cohort of over 600 patients with biopsy-proven compensated alcohol-related cirrhosis, even very low alcohol consumption was associated with the risk of mortality and decompensation, even at a level of 1 unit per week year. And this reaffirms the notion that total abstinence should be recommended for all patients with cirrhosis. So what else can we do to prevent progression of alcohol-related liver disease? Here, investigators from MGH in the United States evaluated the impact of medical alcohol therapies for alcohol use disorder, including a number of different treatments, some of which were off-label, upon the odds of developing alcohol-related liver disease, and then the risk of decompensation among those that already had alcohol-related liver disease. And this group found that in multivariate analysis among patients with alcohol use disorder, these therapies were associated with a decreased odds of developing alcohol-related liver disease, and among those with cirrhosis, a decreased odds of decompensation. I think, again, highlighting the very important point in the hepatology community that treatment of underlying alcohol use disorder should really be a focus of our treatment of alcohol-related liver disease. And then the next several studies highlight the potential central role of the microbiome in alcohol-related liver disease and its treatment. This first study is a randomized double-blind trial evaluating the efficacy of lactobacillus administration in decreasing alcohol consumption and improving liver function. Overall, 38 patients were randomized, and lactobacillus treatment was associated with both a decrease in alcohol intake as well as an improvement in MELD score and liver enzymes, perhaps encouraging the need for additional study to understand the potential mechanistic links between the probiotic administration and this effect on alcohol use as well as hepatitis. The use of fecal transplant for the treatment of alcohol-related hepatitis was also reported. Here are the 3-year follow-up results from this trial of FMT versus standard of care for patients with alcohol-related hepatitis, in which those who underwent FMT had significantly less encephalopathy, critical infections, hospitalizations, and alcohol relapse compared to those that underwent standard of care therapy, as well as a trend towards improved overall survival. I think, again, showing that this is an area that needs additional study. And finally, what about the use of antibiotics in this context of alcohol-related hepatitis? Here's a randomized controlled trial with 142 patients who were randomized to receive amoxicillin clavulanate versus placebo, combined with prednisolone for 30 days for patients with severe alcohol-related hepatitis, which found that there was no significant difference in overall survival at 3 or 6 months, nor improvement in treatment response incidence of HRS or having a terminal MELD of less than 17. However, there was a significant reduction in the probability of developing infection, but I think this probably does not support the use of empiric broad-spectrum antibiotics in this setting. Moving on now to cholestatic diseases, important long-term and follow-up data were presented for novel therapies for both PBC and PSC at the liver meeting this year. Here are data that were presented regarding the use of the FXR agonist cilofexor for PSC in a 96-week open-label extension of this initial trial. And overall, in this phase 2 trial, treatment with this medication resulted in improvements in liver biochemistries as well as markers of bile acid homeostasis. In addition, treatment was overall well tolerated and safe, although there was some pruritus leading to treatment discontinuation in 5 patients. And so we look forward to the results of larger studies of this agent. And for PBC, long-term safety and efficacy of seladelpar was also presented with results from the 2-year long-term follow-up study. In this study, treatment for 2 years with seladelpar overall was thought to be safe and well tolerated and associated with significant reductions in biomarkers of cholestasis and hepatocellular injury, which continued to improve throughout the second year of treatment. And overall, almost 8 out of 10 patients achieved the composite endpoint, and over 40% achieved normalization of their alk phos at the end of the long-term follow-up. So again, looking forward to larger studies to demonstrate the efficacy of this treatment for PBC. And additionally, long-term PBC data was also presented for the use of obeticholic acid. In this study, clinical outcomes were compared between patients treated with obeticholic acid in an open-label long-term safety extension from the POISE trial. And this was compared to controls from 2 large real-world PBC cohort patient registries. And after propensity matching, obeticholic acid was associated with significant improvement in transplant-free survival compared to both of these different real-world cohorts. I think this study is important not only because it demonstrates long-term efficacy, but also that it highlights a new innovative methodology to study these interventions in the long run, especially for relatively rare diseases, utilizing real-world data sets in order to look at long-term. And to round out the summary of new work in chronic liver diseases that was presented, I would also like to highlight 2 interesting interventional studies in metabolic liver diseases. The first is a randomized controlled trial evaluating the efficacy of a novel formulation of trientine, known as trientine tetrahydrochloride, compared to D-penicillamine for the treatment of Wilson's disease. Overall, this new formulation was effective in controlling the serum copper. Interestingly, this was despite lower post-treatment urinary copper excretion compared to D-penicillamine over 24 weeks. However, the new treatment was associated with fewer side effects overall, highlighting the potential for additional studies of this new formulation in this important population. And finally, the results of an open-label phase 2 dose-finding study of the safety and efficacy of a new hepcidin mimetic in the treatment of patients with hereditary hemochromatosis. In this proof of concept study, 16 patients received the agent subcutaneously once or twice weekly, and the treatment was associated with a decrease in phlebotomy rates, in transferrin saturation, and in liver iron content on MRI, and importantly was overall well tolerated as well. So we look forward to larger studies that may provide an alternative to serial phlebotomy for these patients. There was also a large amount of work presented at the liver meeting on patients with cirrhosis, portal hypertension, and I chose to highlight this particular abstract first, as it also reflects another theme from the meeting, which is a focus on disparities in the care of patients with liver disease. In this study, the CDC Wonder database was evaluated to characterize disparities in cirrhosis-related mortality among metropolitan categories, as well as between different race and ethnic groups. And overall, it demonstrated that cirrhosis-related mortality is increasing overall in all different metro categories, but it's the highest and with the largest increase for small metro and non-metro locations, meaning rural locations, and that the largest urban to rural disparities are among Hispanic and Native American populations, highlighting the additional public health interventions that are needed to bring resources to these communities in particular. In addition, important work was presented to help us better define the risk of decompensation and death among patients with cirrhosis. In this study, which included data from a large and diverse metroplex in the United States, over 35,000 patients with cirrhosis were evaluated to determine the impact of other chronic diseases upon mortality risk. And it was noted that 1 out of every 4 patients had a significant, mostly cardiometabolic comorbidity, and that the risk of death was similar between patients with compensated cirrhosis but with multiple cardiometabolic comorbidities compared to those with decompensated cirrhosis, highlighting the need for us to focus more on the management of these chronic diseases as potential modifiers for mortality risk in our patients with compensated disease. AI-based techniques to develop and validate risk predictions models in cirrhosis were also presented. Here, an AI cirrhosis ECG, or ACE score, was presented, which had been previously developed with deep learning-based AI to identify patients with cirrhosis. Here, this model was applied to predict clinical events, including decompensation and liver-related mortality. This group showed that the ACE score can accurately detect the presence of decompensated cirrhosis and was also an independent predictor of liver-related death. And we look forward to more prospective work validating these types of tools moving forward as well. Among the pediatric population, this abstract was also presented evaluating the utility of splenic stiffness as a non-invasive tool to predict the presence of clinically significant varices for pediatric patients with cirrhosis. In this study, splenic stiffness by transient elastography was highly predictive of the presence of clinically significant varices on endoscopy as well as variceal bleeding, and was the best non-invasive predictor of varices that was assessed. However, there was a significant correlation between the splenic and liver stiffness measurements, but perhaps this can be an additional tool to help risk stratify children who actually are in need of a screening endoscopy. So what about new treatments for patients with advanced liver disease to prevent progression? Here are more data in favor of the use of statins for patients with advanced fibrosis from the VA cirrhosis cohort. In this study, patients with cirrhosis were retrospectively assessed, and those on statins were propensity matched to those not on a statin to assess for the association between statins and the development of ACLF. Overall, 30% of patients in the cohort were exposed to statins, and the cumulative statin exposure was associated with a reduced impact of developing ACLF. I think another important finding in the statin and cirrhosis story. In terms of the management of portal hypertension, while for a long time I think we had shied away from the use of peritoneal drains unless we were in a palliative scenario for patients with cirrhosis and ascites, here data were presented on 152 patients with home-based tunneled peritoneal drainage systems and compared to outcomes with 71 patients who got serial LVP as standard of care. These investigators found that the drains had a higher overall 90-day transplant-free survival rate, though after adjustment for confounders, there was no difference in survival. Interestingly, the incidence in SBP was similar between the two groups. However, those with the drains had a slightly higher incidence of hyponatremia, but this is perhaps something that we should continue to consider studying further. Treatment of portal hypertension-related bleeding was also addressed here with an open-label, single-center, randomized controlled trial looking at two different mean arterial pressure targets for patients with cirrhosis and septic shock, comparing a target of 80 to 85 versus 60 to 65. And overall, they found that there was no significant impact on 28-day mortality. And while those with a higher MAP target had improved intradialytic hypotension rates and improvement in recovery of renal function, they also had higher rates of adverse events, I think highlighting our ongoing difficulty in balancing the risk versus benefits for vasopressor support in critically ill patients with decompensated cirrhosis. Liver transplant was also highlighted at the liver meeting this year. Here is important work looking at the interplay between ACLF and transplant outcomes. In this multi-center, US-based retrospective study of patients who were in the ICU prior to transplant, patients with ACLF, even including those with grade 3 ACLF at the time of transplant, had overall excellent one-year post-transplant survival above 85%. However, those with ACLF3 plus respiratory failure did have a trend towards decreased survival in that specific subgroup, although the numbers were small. However, despite these good outcomes, there was a stepwise increase in healthcare utilization with increasing ACLF grade, including length of stay in the hospital and in the ICU, utilization of dialysis, discharge to rehabilitation, and 30-day readmissions. I think, again, highlighting ongoing issues related to transplanting the very sick. In addition, this European multi-center cohort of patients with ACLF3, I think really also highlights the variability in approach to these patients in terms of whether we feel that they are transplant candidates. As they demonstrated in these 20 different European centers across 8 countries, there was significant variability in which patients with ACLF3 were listed for and made it to transplant, which was not dependent upon the volume of transplants in that center or the number of ACLF3 patients in the ICU in that center, but was perhaps based more upon the local center's practice, highlighting a possible inequity in the system, and I would say persistent disagreement in the community about which type of patients are safe to transplant in this acute setting. Several abstracts also address the recent changes that have occurred in allocation policy in the United States, which overall were established to produce broader sharing of organs throughout the United States and decrease the geographic differences in organ access. In this important evaluation of the UNOS data, after 1 year of this new acuity circle policy, Overall, livers were traveling a greater distance on average, but with only a marginal increase in the cold ischemia time. In addition, there was less variation in median MELD score at the time of the transplant throughout the different regions of the country, which was one of the main goals of this new change, and an overall large decrease in the MELD exception points that were granted, likely due to the establishment of a national criteria for exception point review. However, overall, there was no significant change in waitlist or post-transplant outcomes, which I think is another really important point. And when the UNOS data was further examined to specifically look at exception points for HCC over time, this group of investigators looked at 4 different eras between 2005 and 2020. And throughout these periods, there's been a clear decline in the number of transplant with exception points overall, as well, I think importantly, as an evening out in the distribution geographically throughout the United States of transplants with HCC-related MELD exceptions. Importantly, this has not led to increases in waitlist mortality. And as COVID-19 occurred more or less at the same time as these major structural changes in liver allocation in the United States, all of these retrospective data must be viewed with the caveat that it's possible that the pandemic also influenced some of these changes, and the extent to which it influenced will really never be known. And finally, I'd like to segue to the very significant amount of new data that was available at the liver meeting regarding COVID-19 and its impact on patients with liver disease and liver transplant. Important updates from the United States-based multi-center COLDS consortium highlighted the importance of long-term manifestations of COVID-19 among patients with chronic liver disease. In this group, about 25% of patients reported long-term symptoms of COVID-19, which in multivariate analysis was associated with having been hospitalized for severe disease in their initial syndrome. In addition, about a quarter of patients reported moderate to heavy alcohol use, as well as a significant amount of weight gain, pointing to the important additional issues that the pandemic has caused that will likely impact the trajectory of chronic liver disease throughout the world. The impact of COVID-19 in the pediatric population was also reported here in a multi-center collaboration between the NASPGHAN and SPLIT registries of 180 pediatric liver transplant recipients. They showed that even before this potentially milder Omicron variant, the majority of pediatric transplant recipients did quite well with the COVID-19 syndrome. Of these 180 patients, only 30 were hospitalized, 3 in the ICU, none required mechanical ventilation, and none died. And similar to the adult population, the degree of immunosuppression did not appear to be associated with the severity of COVID-19 disease. Vaccines against SARS-CoV-2 were also an important theme of this meeting. In this prospective study assessing both humoral and cellular responses to mRNA vaccines, 182 patients with cirrhosis were compared to 38 controls. And this group showed that patients with cirrhosis, especially those with advanced Child's class B and C disease compared to A, had delayed and suboptimal vaccine responses, here particularly in terms of their antibody response. However, a series of studies were also presented that demonstrated the clinical efficacy of vaccination in preventing COVID-19 disease and related mortality. As an example, a series of studies from the United States VA population looked at patients with cirrhosis as well as transplant recipients. Here, the VA cirrhosis cohort was analyzed comparing outcomes between vaccinated individuals and propensity-matched controls, and found that vaccination was associated with a reduction in COVID-19 related hospitalization and death among patients with cirrhosis, but that this improvement in outcomes started about 28 days after the initial vaccine dose. This group then looked at outcomes of patients with cirrhosis who developed COVID-19 after vaccination and found that overall post-vaccination COVID-19 was associated with significantly better outcomes than those that were unvaccinated, even after only partial vaccination. And finally, again in this VA cohort for liver transplant recipients that received full vaccination, this vaccination was associated with a 64% decrease in COVID-19 disease, 58% decrease in symptomatic COVID-19, and an 87% decrease in death among liver transplant recipients with COVID-19. Again, I think crucial data on the clinical efficacy of vaccination in our patients. In summary, many important new findings were presented at the liver meeting this year, including regarding alcohol use and alcohol-related liver disease treatment, novel therapies for cholestatic and metabolic liver diseases, and regarding the care of patients with decompensated cirrhosis and ACLF. In addition, the impact of new transplant allocation policies were assessed. And finally, important updates on COVID-19 outcomes and vaccine efficacy in our patients were reported, I think further supporting our efforts to encourage vaccination for all of our patients to do all that we can to protect them from this pandemic. Thank you for your attention, and I look forward to your questions.
Thank you to all speakers. Because of time restrictions, we will pass the second part of this session, and two cases will be presented by Dr. Nergiz Ekmen and Dilara Turan. I would like to invite Nergiz Ekmen first to present her case.
Hello, everyone. I am Dr. Nergiz Ekmen. I am a gastroenterologist. I am working in Gazi University Hospital in Ankara. I would like to start by thanking American Association Study for Liver Disease and Turkish Association for Study Liver for the organization of this meeting. I will present a case from general hepatology. 18 years old male patient was referred for hospital or clinic due to increasing liver enzymes. His main complaint was fatigue. He had no additional comorbidity. He had no history of alcohol consumption or drug abuse or herbal supplement usage. According to the anamnese of patient, he was not using any medication, but he had a history of erythrocyte stage 2 years ago. In his physical examination, there was no pathological finding, including the peripheral sign of chronic liver disease. You can see his physical examination finding in this slide. Initial tests showed that aspartate aminotransferase level were 3 times. Alanine aminotransferase level were 8 times, and gamma-glutamate transferase level were 2 times higher than upper limit. As you can see, he had mild hyperbilirubinemia. There was no other pathological result in this initial test. You can see visceral hepatitis markers in this slide. Anti-HPV antigen was positive due to his HPV vaccination, and all the rest was negative. So the patient had no clue of viral hepatitis. During his further investigation, autoimmune liver protein shows anti-small muscle antibody, anti-nuclear antibody, and anti-soluble liver antibody positivity. Also, immunoglobulin G levels were higher than upper limits. Abdominal ultrasonography shows that his liver has a normal size and shape. Parenchyma was homogeneous, and bits of hepatic portal vein were normal. Also, size and shape of spleen and width of splenic vein was normal. According to all these data that we gathered, we decided to make a liver biopsy to confirm this autoimmune hepatitis diagnosis. So, percutaneous ultrasound-guided liver biopsy was performed. In this picture, you can see the tripod biopsy sample. In this picture, show the portal area colored in purple. If we zoom the sample, which I showed in the previous slide, you can see that there are areas with intense plasma cell infiltration. You can see bile duct on the left side with minimal deformity and mild inflammatory injury. This picture show irregularity of post-operational border interface activity. In other words, seasonal necrosis. Focal area and sublamellar area is shown in this slide, and you can see the focal necrosis area in here. If you zoom the sublamellar area that I showed in the previous slide, you can see the compliant necrosis area. And you can see plasmacyte in compliant necrosis area in this slide. In this slide, I would like to show you that there is no nodularity and fibrotic activity in this sample. As a summary, the biopsy sample of the patient was compatible with autoimmune hepatitis according to its classification. Necroinflammatory activity was calculated as 9 to 10 points out of 18 points, and fibrotic stage was calculated as 0 to 1 out of 6. So according to all the information that you gathered until now, you can say that this patient, that this patient has autoimmune hepatitis. We calculated international autoimmune hepatitis group score as 18 points, and the simplified autoimmune hepatitis score as 8 points. So shortly, the patient was diagnosed with type 1 autoimmune hepatitis. During the investigation period, liver enzyme levels were doubled within 2 months. On the other hand, serum bilirubin and international normal ratio levels were normal. Also, immunoglobulin G levels had a rising trend. If you were the doctor of this patient, which was newly diagnosed with autoimmune hepatitis and his liver enzymes were constantly increasing, which first-line treatment would you prefer? In the first-line treatment, 50 milligram prednisolone was started for 2 weeks. We continued treatment as 50 milligram prednisolone. Then first dose was tapered 5 milligram each week. Unfortunately, during this period, patient came to our clinic with complaints which were Cushingoid appearance, acne, especially is in his back area, and cytia in his abdomen and arms. Also, he described mood change due to his complaints, which were related to his treatment. His prednisolone treatment was stopped and switched to budesonide and azathioprine treatment. In this slide, you can see the 6 months liver enzyme curve. From the beginning of treatment, after 4th week, you can see that liver enzymes were slightly increased. However, in the 1st month of treatment, rise of enzyme became more prominent, and during the 6 months of the treatment, alanine aminotransferase level reached to approximately 300 milliliters. During this period, patient continued to use budesonide 9 milligram and azathioprine 100 milligram. This slide shows the immunoglobulin G levels during the treatment period. After the 4th week, you can see that immunoglobulin G levels were increased. Which medication would you prefer as a second-line treatment? So you saw the cause of disease, first-line treatment. Would you consider to have a second-line treatment plan for this patient? If your answer is yes, what would you prefer as a second-line treatment? Shortly, let me tell you what we have done for this patient. We stopped the previous treatment and we start nicotinic and low-dose prednisolone. During his knee treatment regime period, liver enzyme and immunoglobulin G levels were fluctuated but never normalized. What do you think about the effectiveness of this treatment? After the beginning of second line treatment, unfortunately, biochemical remission was not successful within 1 year. So what did we do? We switched nicotinic mofetil with tacrolimus while we continue prednisolone treatment. As you can see, 18 months after the tacrolimus treatment, liver enzyme and immunoglobulin G levels were fluctuated but never normalized like the previous time. I would like to ask you some questions. Firstly, how should we plan this patient treatment? Secondly, should we continue with same treatment? If your answer is yes, and for how long? And do we switch to another treatment? If your answer is yes, which one? Thank you for your attention.
Hello again. I would like to invite our earlier speakers, Dr. Elizabeth Varna, Elliot Taper, and Aparna Goyal. And in addition to them, our colleagues Ersan Özaslan and Gökhan Kabaçam, we will try to discuss about this case. And this is a treatment-resistant autoimmune hepatitis, and what would be the panelists think about, and what's the solution? Still, that patient did not reach a good treatment response.
Hi, everyone.
Okay.
I'm Aparna. I can get started with a few comments on the case. So thank you for that presentation. I hope you can all hear me okay. I'll start just with a caveat that I'm not a pediatric hepatologist, so maybe the 18-year-old age range is a little bit different, but it does sound like a challenging case in somebody that has an incomplete biochemical response to your first line management, your first line therapy. So, and this happens obviously the goal of therapy for autoimmune hepatitis is to induce biochemical and histologic remission, and we see that in doing so, you can improve. This patient's lucky, doesn't have fibrosis right now. But when you are able to do that in patients that do have scarring, you can cause regression in fibrosis and really improve patient outcomes. So the goal really should be biochemical and histologic remission if we're able to do that. I think, so a few things. One is this patient obviously didn't respond to azathioprine initially. Usually if they don't respond to azathioprine, there's only about a 20 to 30% chance that changing over to mycophenolate mofetil will actually capture remission or cause remission. So there's not a high chance that the mycophenolate acid would have worked. And perhaps instead of switching it over to mycophenolate acid, you could have used the azathioprine and added on the tacrolimus. Sometimes that has a potential benefit of the dual action of both the antimetabolite and the calcineurin activity in patients. So this patient unfortunately probably needs dual or triple immunosuppression to at least induce remission, keep them in remission for some period of time, And then down the line, you can think about weaning therapy depending on what their serum immunoglobulin levels respond and how their ALT level responds. But right now, it looks like they're on a low dose of steroid and tacrolimus. I would consider either adding the mycophenolic acid back on or the azathioprine back on to making it triple immunosuppression for this young patient and trying to achieve the biochemical remission.
Okay. In combination treatment, what would you suggest for the prednisolone dose, steroid dose?
Yeah, I think the lowest possible dose is obviously the best. That is something else that you can play around with for him. You're absolutely right. He was just on, I think, 5 milligrams of prednisolone. So you might need to increase the dose briefly or consider switching it over to the higher dose of budesonide just to limit the overall side effects of the systemic steroids. Budesonide, obviously 9 milligrams. In our younger population, the steroid dose when we're initially starting therapy is usually about 1 milligram per kilogram per day. We try not to go higher than that in the younger population, but he probably doesn't need to be on that high of a dose right now, but you might need to increase it to maybe 20 milligrams for a brief period while you're adding on therapy and then start to wean it down again. Or consider switching over to budesonide while you're adding on therapy.
Yes, Gökhan.
Another comment?
Yeah,
Tamam, Gökhan.
I want to have some comments as well here. So this patient is a young patient with anti-SLA LP positivity who has some bad prognostic, incomplete response parameters in the clinical picture. So it's very difficult. And I agree with the other colleagues that we should continue and search for some other treatment because he also has interface hepatitis in the baseline biopsy. And before seeing that fades away, we cannot stop the treatment and we should have another combination, maybe a TACRU plus MMF can be a better combination here as far as I think. But I want to ask my colleagues if they have a experience in combining allopurinol with azathioprine to increase the effectivity in such a unresponsive or complicated patient.
I'll jump in to say that I really like the framework that Dr. Goel laid out and the use of combination therapy, particularly when you have somebody like this who seems to be like on the cusp. They just need one extra push. But the question here is about how can we optimize the use of azathioprine? And in my practice, if I don't like what I see, I do check azathioprine metabolites and make a educated decision about how to either get away from a shunt problem or optimize the 6-TGN level. As it gets towards 200, there's some data that you're more likely to get some remission. And if your 6-TGN level is quite high, then I don't think there's any benefit to playing around with it at all. If you have a particularly elevated 6-MMP level, then what you're seeing on that azathioprine is not a lack of efficacy, but rather some toxicity, and that's where allopurinol comes in. So, but in general, before I go to allopurinol, I try a trial of splitting the dose morning and afternoon, which has been associated with a reduction of shunt for reasons that I really don't understand. But it feels like a much more slick trick than adding allopurinol. But I do like that idea, but it should be based on a formal assessment of azathioprine metabolites.
Okay.
Do we have any
MMF available, Dr. Taper? If MMF available, would you still to figure out the 6-TG level or just try MMF?
Yeah, in this case, I kind of like the framework that Dr. Goel laid out. where I think we're at the end of the line for this particular person, and we're thinking about adding on additional therapy. But in my patient who is not responding, that's when I'm going to metabolites before MMF, because the likelihood of success is far from assured when you switch, just as you've heard. But I'm not checking it in everybody, just when I don't like what I see.
Thank you.
Do we have any goal for trough levels of tacrolimus in these patients?
Yes,
Yes,
yes.
it may have some value, I think, because actually tacro and MMF are empirical treatments, even for incomplete response. So in Turkey, we do not have a general TPNT measurements or the theoprene metabolites, and empirically use mycophenolate mofetil or tacrolimus. For those cases, in the literature, tacro trough level was between 1 to 8, and the oral dose were between 4 to 10 milligram. So in such a case, trough level of 5 to 7 may be appropriate to a recent consensus in Journal of Hepatology. And I agree with our colleagues in this patient, MMF plus tacrotherapy, but actually this patient is in first treatment phase is a very responsive to classical steroids. Budesonide is not studied in acute cases. Budesonide is suitable for mild cases and non-cirrhotic cases. So I wouldn't prefer budesonide in such a patient, acute presentation, and the initial phase details is missing for me. But I agree with the tacro trough levels and the other tacro MMF, and a brief elevation of conventional prednisolone up to 20 milligrams if he tolerates. Okay.
Thank you, Ersan. If
Any
there is no other comment, I would like to move the other case, but before we move the other case, I want to say that unfortunately one of our panelists, Murat Dayangaç, is not here together with us today because of a health problem. He is having an operation. I wish him well soon and hope that he will regain his health as soon as possible. Our prayers are for him. And now I want to move on to the second case. I would like to invite Dr. Dilara Turan.
Dear participants and panelists, first of all, I would like to point out that that's a great pleasure to be a part of this meeting. Today, I will be presenting a case about post-transplant complication. A 64-year-old man with LDLT presented to our clinic with symptoms of persistent abdominal pain, weight loss, and fever. The patient underwent transplantation in January of 2011, and the donor was patient's son. The patient's initial complaints began about 7 to 8 weeks ago. Now let's start with patient's history. The patient was diagnosed with HBV in 2001. Then his serum HBV DNA was higher than 2000 IgU per milliliter. The patient's liver biopsy showed a nodal high score of 8 and a fibrosis score of 3. Anti-caviar treatment was initiated. Serum AFP and abdominal ultrasound were performed for HCC surveillance every 6 months. Then a 30 by 32 millimeter lesion was identified in segment 7, and the lesion was verified with on CT. Transarterial chemoembolization treatment was applied twice. Before liver transplantation, the patient's HBV DNA was negative and serum AFP was normal. During the patient's, during the patient's follow-up, anastomotic stenosis was confirmed on MRCP, and then ARCP treatment was applied. In February of 2009, the patient presented with symptoms of fever, fatigue, and weight loss. He was referred to our hospital for ARCP treatment in April 2009. All system reviews were normal except for the gastrointestinal system. He had persistent abdominal pain that was unrelated to meal and was localized primarily in the right upper quadrant. Weight loss approximately 6 kilograms within 3 months and loss of appetite. And also the patient's physical examination was normal except for fever of 37.4 degrees Celsius. The patient's fever was uncharacteristic. He also had right upper quadrant and hepatomegaly. Okay. Here we can see, you can see the initial laboratory test. His blood urea, ALP, GGT and LDH were higher than normal, and also he had an anemia. Actually, I want some question. Which treatment strategy is optimal for HPV prophylaxis? I need to know how to figure out the patient's HPV prophylaxis.
Dr. Taper?
So the question is how to select a HPV prophylaxis after liver transplantation, and in general, right? These are some of the highest risk patients for reactivation, and in our practice, we are selecting a agent that has the highest barrier to resistance, and for that, you really have a few options: entecavir or the two versions of tenofovir. And local practice patterns are highly variable. It's also dependent on the cost of the medication to the patient, which in the United States isn't completely unpredictable. But in general, we're selecting entecavir for patients like this.
Can I have a comment?
Yes, Gökhan, please.
Some of you may know that TASL have already published the guidance about the post-transplant prophylaxis strategy in the HPV patients. And as you have already said, Dr. Tepper, the patients with HCC are risky for the recurrence. So we combine the high potency nucleoside analogs with HPIC in these patients for at least 5 years in Turkey. I know in many new studies, there are some studies that shows the HPIC is not necessary in these patients and increasing the cost. But still, we are a endemic place with hepatitis B, and still the hepatocellular carcinoma is mainly due to the hepatitis B in our country. So we have some extra precautions.
Thanks, Gökhan. Can we go on?
Thank you. When he was referred to our hospital, he was receiving entecavir and monthly hepatitis B immunoglobulin G prophylaxis due to high risk. And then we performed abdominal CT. There were multiple irregular circumscribed solid lesions were identified in the liver, the largest of which was 70 millimeter in diameter in especially localized segment 6. In venous phases, hypointense, and without arterial contrast enhancement. Intrahepatic and extrahepatic bile ducts were normal. Several spherical lymph nodes, the largest of which was 12 mm in diameter at the level of the hepatoduodenal and hepatogastric ligaments. There were no pathological lymph nodes or suspected lesion on neck and thorax CT. On MRCP, hyperintense lesion in T2 AG sequences of 30 mm in segment 7. Now, I would like to know your opinion. What is your differential diagnosis?
Gökhan, what will you say?
Now, this patient was a HCC patient in the baseline, and but he or she, I don't remember the sex, but she was within Milan criteria, so a low risk patient. And this relapse or this tumor we see here in the liver in the transplant isn't in line
sure if it is
with
tumor.
HCC. Yeah, I think it's not a it's like a tumor, yeah, but it's like some sort of a metastasis or some other, it doesn't behave like an HCC. The LDH is high. It has cholestatic pattern without any obvious problems in the MRCP, which is more in line with the infiltrative problems. So this can be some other condition like a metastatic tumor or some lymphoproliferative condition, something like that.
You suggest PET CT?
Definitely, for sure, yeah.
With your permission, I would like to continue.
Dr. Taper, could you say something?
Oh, I have little to add to that.
Okay, go on, Dilara.
Okay. The case was presented at a multidisciplinary consult that included members from hepatology, radiology, and transplant surgery. Our experienced radiologist didn't consider lesion as HCC or cholangitic abscess, and liver biopsy was planned for the diagnosis. Okay. Not that, yes. All liver structures except the bile duct are infiltrated by diffuse lymphoid cells. As you can see on the circular lymphocytes intensely stained positive for CD20, and there's some problem or internet connection. Sorry. Yes. And CD45. And the key 67 rate was over 90%. Our patient was diagnosed as post-transplant lymphoproliferative disorder. Contrary to expectations, tissue EBV PCR was negative. And then we evaluated the case with our department of hematology, and they performed a bone marrow biopsy, which was recognized as normal. Unexpectedly, there was no pathological FDG uptake on PET-CT. In summary, our patient was a 64-year-old male, older than expected, with ECOG performance of 0 to 1. He was diagnosed with post-transplant lymphoproliferative disorder, monomorphic subtype, diffuse large B-cell lymphoma. Tissue and blood EBV PCR were negative, also CMV DNA. There were no extranodal involvement, bone marrow involvement, and there was no pathological FDG uptake. As you know, we know the level of FDG uptake correlates with the grade of tumor. The interval time is 8 years between liver transplantation and PTLD time. As Dr. Taper also mentioned, PTLD remains a major complication after liver transplantation. Now, what is your choice of the treatment?
May I ask a question, Dilara?
Yes, of course.
Do you know the basal serology for Epstein-Barr virus in the donor and the recipient?
Okay. Unfortunately not, because he was referred to our clinic about 8 years later after liver transplantation, but his serum HBV immunoglobulin G was positive.
I would change immunosuppression protocol. I will start everolimus, and also this patient should take R-CHOP therapy, in my opinion.
Any other comment?
So we usually will also try to minimize or withdraw immunosuppression in these patients to see if there's a response. I mean, he's EBV negative, and the time interval for him to develop PTLD is quite late. So I don't know how aggressive his tumor is going to be, but some of these PTLDs will respond just with immunosuppression withdrawal or minimization. So I think he was on mycophenolic acid and on a calcineurin inhibitor, and we normally will begin with stopping the mycophenolic acid and minimizing the calcineurin inhibitor, and if needed, add everolimus to that. And if there's no response following that, so repeating some sort of staging with a PET scan or with just a CT scan, and if he continues to have PTLD and high disease burden after that, then we'll think about rituximab, or if no response to rituximab, then potentially more systemic chemotherapy like R-CHOP.
But as far as I thought, the lesions are very widespread. So if I'm not sure if there will be time to wait. So I think we should be aggressive initially because of the patient's age.
I agree. It's so hard. I think it's something that we talk with our oncology colleagues about in these challenging cases to find out. It has to be, whatever we do has to be with a short interval follow-up to see if there is a response. So if we don't start with aggressive chemotherapy, and sometimes our oncology colleagues will, send off genomic analyses to really find out exactly how aggressive this tumor could be. And if it doesn't look like it's that aggressive, and if there's a improvement in imaging after just 4 to 6 weeks of decreasing immunosuppression, then we can sometimes save these patients from receiving systemic chemotherapy.
Okay, Dilara.
We discussed the case with multidisciplinary tumor again. That include members from pathology, hematology, oncology, also transplant hepatology. Our team chose not to initiate any conventional chemotherapy or rituximab. There were no organ dysfunction, multi-organ involvement, and FDG uptake on PET-CT. Therefore, in light of the literature, we choose the reduced dosage of immunosuppression. MMF treatment was discontinued, tacrolimus dosage was reduced. Also, we know that everolimus and sirolimus induce the remission of PTLD without chemotherapy. Everolimus was added to the patient's treatment. On the examination that was performed 8 weeks after the treatment change, the lesion at liver segment 6 had regressed to 30 millimeter. The other lesions in the right lobe of the liver had regressed. The control biopsy was performed 9 weeks after the diagnosis. Ödematoous stroma with a superior lymphoid cell population dominated by apoptosis were seen. Also, the slides were interpreted as complete remission by the same pathologist. And the patient's clinical symptoms had fully regressed at 12 months after the diagnosis. Here you see the fully recovered CT waves of the liver at 12 months after the diagnosis. Ongoing radiological and clinical follow-up has shown complete remission until now. What should be the follow-up plan?
I would continue with the same regimen.
What did you do, Dilara?
Yeah. We just follow up patients. Thank you for your attention.
Thank you for your presentation. It looks like we have run out of time, and I would like to all the speakers and panelists for their valuable contribution to our session. And I would like to thank you all the audience for taking time out of their busy schedule to join us today. And I would like to say goodbye. Have a nice weekend. Bye-bye.
Bye-bye.